welcome everyone. I'm here to present the progress of my PhD titled as the Neurocognitive Development of Children with Perinatal Insults. I'm Dóra, Bodócs, a cognitive psychologist and a first-year PhD student, and together with my team we are working together to achieve our vision, which is to give every child a chance to speak on time. Our current mission within this vision is to reveal the early indicators of language difficulties and its connection to perinatal insults. I have two ongoing projects at the moment. Both of them will focus on the different biomarkers' prognostic accuracy to detecting delayed language development in children with neonatal encephalopathy. The first project is the systematic review and the meta-analysis, while the second one is a single-center Retrospective Cohort Study. Let's start with my first project. So, asphyxiated encephalopathy, which affects 0.5 to 3 per 1,000 live births in high-income countries, jeopardizes the neurocognitive development of the affected children. Some studies revealed impaired speech and language skills in these children, even when they survived without any functional motor deficits. The late diagnosis of neurocognitive deficits and language delay may worsen learning difficulties and can lead to poor social growth. Currently, there is not a detailed exploration of the domain-specific cognitive outcomes in children with neonatal encephalopathy, even when they survived with a good general neurological outcome. The early accurate prediction and the intervention of developmental delay will result in a better developmental trajectory and better adult performance. Based on these pillars, our aim is to find the most accurate predictors for early detection of neurocognitive deficits. The clinical question of my first project is that is MRI an accurate prognostic tool for predicting delayed language development in children with neonatal encephalopathy? We are using a PFO framework where the P stands for children with neonatal encephalopathy, the prognostic factor is the MRI, and the outcome is the prediction accuracy of language development. Our hypothesis is that the MRI is an accurate marker in the prediction of delayed language development in children with neonatal encephalopathy. And we hope that our result will lead us to early prediction and intervention based on this prediction. You can see my search key and the flowchart selection here. The search key contained 4 domains and were conducted in 3 databases. The search resulted in 22 eligible full texts. You can see my first project progress here. We are currently waiting for more statistical analysis to be done, and we are currently writing the manuscript as well. Let me present the first figure of my project, which is the odds ratio of language delay after a neonatal MRI detected brain injury. Here we used odds ratio, and if the given result is at the right part of the figure, that means that those children who had MRI injury during their neonatal period had higher chance to develop language delay. We included 10 articles with approximately 350 children's data involved, and the neurodevelopmental follow-up period of these studies ranged for 18 months to 5 years. You can see that the heterogeneity is low to moderate, which can be explained by the small patient number of these studies. You can see that the odds ratio here is 5.89 with a confidence interval of 2.72 to 12.73, which means that those children who had a neonatal MRI injury had almost 6 times higher odds to develop language delay later on their lives. On my second figure, you can see that we also did a subgroup analysis based on the MRI pattern of the injury. We did this subgroup analysis based on a widely used MRI scoring system, the Barkovitz scoring system, with the help of a neuroradiologist. The first subgroup is containing those data where the children had an MRI injury at their basal ganglia thalamus area. The second subgroup including the watershed area injuries, and the third subgroup including the mixed group, which means that those children had injury both of the previously mentioned areas. Unfortunately, none of the analysis were statistically significant, but it's highly important to reveal these injury pattern connections to the language difficulties, because it's with these results, we can make more precise and more accurate treatment plans and predictions regarding to the language development of these children. Currently, the manuscript drafting is at the part when we finish the methods part, and you can see the expected deadlines here at this slide. So let's move to my second topic, which is closely related to my first one. This is the SANE study, which stands for Speech of Kids After Neonatal Encephalopathy, and is a single-center and Retrospective Cohort Study. So as the previously mentioned background, here our clinical question is that what's the most accurate prognostic tool for predicting delayed language development in children with neonatal encephalopathy? Here we are also using the PFO framework, where the P is also the children with neonatal encephalopathy. The prognostic factors are the MRI on a special highlight on the diffusion abnormality of the corpus callosum, the amplitude integrated EEG, and the blood gas markers. The outcome is the prediction accuracy of language deficits. Our hypothesis is that the MRI, corpus callosum MRI quantified diffusion abnormality provides the most accurate prediction of delayed language development. And we're also hoping that our results would lead us to early prediction and intervention. Here you can see my study design. The first examination phase containing the neonatal blood gas marker values and the amplitude integrated EEG values. The second examination phase is the MRI scan at the age of 4 days. And these children underwent a cognitive and a linguistic assessment at the age of 2 years. And currently we are at the fourth phase of this study, where we are assessing cognitive and language skills of them at the age of 4 to 7 years, and this phase containing free in-person examination with an IQ test and the global language test, the COBAC, as well as several online parental questionnaires. And the fifth phase will be the re-evaluation of their MRI. As you can see, we are targeting a patient number of 93 children, and we already contacted 46 of them. The data collection is finished with 38 of them, and we are and several studies are going with 7 children, and we lost 1 children during the follow-up period. You can see the ethics approval number here and the clinical trial registration, and we also visited several cities for the data collection. We are planning to start the MRI data reanalysis during this September, and we're planning to finish the data collection by the winter of 2026. Here you can see some primary results. As you can see, almost a third of the children developed language delay. And you can also see some other developmental disabilities that we are screening the children for, as well as some global parameters of our cohort. We are currently at the manuscript writing status for my protocol, and we almost finished with them. That. We will have a statistical meeting at the beginning of September, and after that we are planning to submit the protocol manuscript to the +1 journal, which is a Q1 journal with an impact factor of 2.6. So in a summary, we are planning to submit my first manuscript during the September of this year, and the protocol manuscript of my second project during this October. And I would like to end my presentation with a Murakami Haruki note that it's all a question of imagination. Our responsibility begins with the power to imagine. And thank you for your kind attention.
Would you please tell us a little more about your inclusion criteria or methods in your second project?
Yeah, sure. I actually have a supplementary slide for that. So you can see the detailed inclusion and exclusion criteria here. We are including those children who were born on the 35 or more weeks of gestation and had perinatal asphyxia and received whole-body therapeutic hypothermia for moderate to severe neonatal encephalopathy. And it's also important, based on my structure of the study, that these children attended the follow-up examination at the year of 2 to, and of course has parental informed consent. We excluding those children who have hearing loss or were raised in a multilingual language environment, as it can seriously influence their language development, and we also excluding those children who were born with congenital abnormalities, suffer from metabolic disorders, or had a postnatal collapse or brain injury caused by the neonatal encephalopathy, or had severe motor impairment at the age of 2 years.
You mentioned in your second project that there was one loss of follow-up or one loss of patient. Maybe you could explain why he was lost, from what reason?
Yes, so we didn't know previously that she was raised in a multilingual environment, and this only came up when we had the in-person examination with her, and this is why we excluded her.
How could the different inclusion criteria of the studies included in your meta-analysis influence the results, or how much did they differ? So who did they do the MRIs on in those studies?
So the inclusion criteria?
Yes. So were those quite different populations regarding these inclusion criteria in the meta-analysis?
We had really strict inclusion criteria for my meta-analysis. We, for example, had inclusion criteria for the minimum neurodevelopmental outcome, which were the 18-month, as well as that these children needed to undergo therapeutic hypothermia. So based on these really strict, and we also had some inclusion criteria for the type of the studies. So based on these really strict inclusion criteria, I think that the studies that we included in the meta-analysis are quite similar.
You mentioned on one of your slides you want to investigate biomarkers in your second project. Could you please clarify which biomarkers do you mean, which one do you want to investigate?
In my second project.
Yes, in your second.
Yeah. So as I mentioned, the MRI biomarkers with the scoring system of the Wiki scoring system, as it's it's a really quite new MRI scoring system, including a wide variety of MRI markers, not only the structural or the functional scans, but also the DTI measurements. And we are also want to include the amplitude integrated EEG measurements of these children at their neonatal period, as well as some blood gas markers, for example, the lactate.
I have a question related to the second project, especially the exclusion and inclusion criteria. So you write there that the brain injury not caused by hypoxic ischemic encephalopathy is an exclusion criteria, but as far as I remember my experience in the perinatal intensive care unit, so these patients go to MRI 1 or 2 days after the birth, right? So how can you make sure that they don't get a secondary brain injury after the second day of their life? For example, these patients sometimes get sepsis or some kind of infection. Many things can happen.
Unfortunately, as a psychologist, I don't I can't really see into the details of this medical part of the care of these children. Therefore, I can't really answer this question.